Welcome to today's critique, where we are examining the Colorectal Surgery Code, a deeply comprehensive, visually driven surgical guide by Dr.Atef Ahmed that details open, laparoscopic, and robotic techniques. And we are just going to jump right into our first piece of feedback today because, well, the aggressively commercial promotional messaging surrounding the book inadvertently undermines the stoic academic authority established within the surgical text itself.
Yeah, it really does. I mean, when you open the actual manuscript, you find this text that is deeply rooted in, clinical humility and rigorous surgical discipline.
Right.
The preface and the dedication alone set this tone of just immense reverence for the surgical profession and patient responsibility. But then the external marketing strategy relies heavily on this frantic retail-style urgency that creates a profound cognitive dissonance before you even read the first page.
Totally. And the severity of that tonal whiplash is exactly what we need to address first. Because, the promotional materials utilize phrases like, massive 80% off all medical books? Yes, you read that right.
Yeah, complete with the neon graphics and all that.
Exactly. Neon graphics, multiple exclamation points, brightly colored shopping carts, and this really heavy push to apply the promo code AR665398 immediately. And the core material inside is remarkably strong. It's academically prestigious, incredibly detailed regarding all the techniques.
Oh, absolutely.
But for a senior fellow or, say, a surgical residency program director evaluating the text, this hyper-commercial external presentation almost forces them to second-guess the clinical rigor of the actual content.
Well, right, because in medical literature, trust is the absolute paramount currency. The reader is looking for an authoritative voice to guide them through high-stakes life or death decision-making in the OR.
Yeah, exactly.
And when the entry point to that knowledge mirrors the aesthetic of like a midnight clearance sale or a fast fashion website, it inadvertently signals that the product might be a superficial study guide rather than a definitive operative companion.
Like the medium is the message.
Exactly. The medium is the message. And right now, the medium is broadcasting retail urgency, not surgical mastery.
Let me just look at this from the author's perspective for a second. Because surgeons are consumers too, right? I mean, they have budgets, residency programs have really tight financial constraints. Is there really a danger in running a highly visible, aggressive discount campaign just to get the book into as many hands as possible?
I mean, there's nothing inherently wrong with discounting the material to drive accessibility, but medical professionals make purchasing decisions based on perceived authority, not just price.
Right.
If a residency director is buying textbooks for their entire cohort, they want to feel like they're investing in an elite pedagogical tool. So the discount is appreciated, but the phrasing of, massive 80% off, it triggers this subconscious skepticism.
Yeah, they start wondering, why is this discounted so heavily?
Precisely, they think, is the anatomical data outdated? Is this self-published without peer review? You just never want the buyer questioning the integrity of the clinical data simply because the marketing feels desperate.
Right. It's like walking into a deeply respected, hushed medical library and being immediately greeted by a stadium announcer. The quality of the books is excellent, but the entry experience makes you question where you are. So the move here is to realign the marketing language and visual aesthetic to match the prestige, gravity, and educational mission of the book's core philosophy.
Which is an entirely solvable translation problem. It doesn't require abandoning the discount at all. It just means translating the offer into the professional dialect of the target demographic.
So to execute that, the author could reframe the discount, right? Instead of a massive 80% off retail sale, they could rebrand it as a surgical education initiative, or maybe a trainee access grant designed to democratize high-level surgical knowledge.
Oh, democratizing knowledge is the exact right frequency for this audience.
Yeah.
It speaks directly to the academic ethos. It takes what was previously a cheapened financial transaction and elevates it into this noble pedagogical mission.
Along those same lines, the promo code that AR665398, it can be presented as an exclusive VIP access code for the medical community, or, a resident scholarship code.
Right, exactly.
And visually, shift the marketing materials away from the neon lights and the shopping cart urgency. Lean into the muted, sophisticated, anatomy-focused visuals that make the book itself so strong. Like put the code wheel or those embryologic plane diagrams right on the promo.
And that visual shift does a ton of heavy lifting. If I see a promotional post featuring this beautifully rendered illustration of the avascular white line of TOLD, the anatomical landmark surgeons use, and that image is accompanied by language about a trainee access grant, my immediate assumption is that this is a premium academic resource.
Right. It completely changes the vibe.
It makes the marketing an extension of the book's educational value. It signals to the senior surgeon that this is a tool worthy of shaping the minds of their residents.
But even if we fix this marketing mismatch and get the right surgeons eagerly opening the book, they are immediately going to hit a structural wall in Chapter 1. Because the foundational Master Colorectal Surgery Code wheel and decision pyramid, introduced early in the text, fail to adequately encompass the emergency surgical scenarios detailed later in the book.
Yeah, and the conceptual models in Chapter 1 are brilliantly designed. As cognitive anchors, they're great. The code wheel is a fantastic visual distillation of these really complex surgical pathways. But you hit on a crucial structural dynamic that needs some serious calibration.
Because those foundational models are heavily biased toward elective oncologic cases. I mean, the code wheel explicitly targets metrics like ELAS, which are the enhanced recovery after surgery protocols, right?
Right, the stuff you do days before an operation.
Exactly. It targets an albumin less than 3.0 and a minimum 12 lymph node harvest. But when a reader reaches Chapter 15, Emergency Open Surgery, this initial framework feels totally disconnected from the chaotic reality of toxic megacolon, or a closed-loop obstruction, or fecal peritonitis.
Yeah, the core philosophy of anatomical respect and oncologic clarity just doesn't seamlessly translate to the damage control and Hartmann procedure realities required in a highly unstable patient.
Right. In a Hartmann procedure, you're just trying to divert the bowel and save the patient's life when an anastomosis is too risky.
Exactly. In an elective setting, we have the luxury of time, preoperative optimization, absolute oncologic radicality. We want perfect margins and comprehensive lymph node retrieval.
Sure.
But in a 2 a.m. trauma or emergency scenario, the paradigm completely flips. The objective is no longer a negative resection margin. The objective is simply keeping the patient alive long enough to make it to the ICU.
Yeah, which is a totally different mindset.
Right. So if the foundational framework of the entire book only represents the elective pathway, the reader is left without a mental model when things go catastrophically wrong in the emergency bay.
So the suggestion here is to adapt the primary visual frameworks at the beginning of the book to explicitly accommodate a dual pathway approach for both elective and emergent care.
Yes, but integrating a dual pathway without losing the elegance of the original design is the tricky part. Like, how does the author modify the visual without turning it into a cluttered, unreadable mess?
Well, for concrete examples, they could introduce a crisis code wheel on the page adjacent to the master wheel. So in this emergency version, replace preoperative optimization with hemodynamic resuscitation and sepsis control.
Oh, that makes sense.
And swap oncologic clearance with damage limitation and rapid source control. Or alternatively, modify the base of the existing colorectal decision pyramid to split into two foundational paths: elective physiology and emergency stability, ensuring the reader understands how the decision tree branches immediately based on patient acuity.
The idea of the crisis code wheel sitting right next to the master wheel visually represents the split reality of a general surgeon's life. It acknowledges that duality perfectly.
I do wonder, though, and let me push back on this a bit, if we add a second crisis wheel or split the pyramid, do we risk cluttering the elegant simplicity that makes Chapter 1 so memorable? Like, might it overwhelm a junior trainee trying to grasp the absolute basics if we throw multiple frameworks at them on page 5?
It's a valid concern for instructional design, for sure. But I would argue the exact opposite is true in a clinical context. Separating the elective and emergent frameworks actually reduces cognitive load, especially in a crisis.
Really? How so?
Think about the physiological state of a junior trainee faced with a perforated colon at 2 a.m. Their patient's blood pressure is bottoming out, the anesthesiologist is yelling, their cognitive bandwidth is just severely constricted.
Yeah, it's total chaos.
If they are trying to mentally adapt an elective model, trying to figure out how a 12 lymph node harvest rule applies to a patient in septic shock, they're going to experience paralyzing cognitive overload.
Oh, I see. So the single model actually creates confusion because it forces the brain to filter out irrelevant elective steps during an emergency.
Exactly. By giving them a distinct stripped-down crisis model, you are actively giving them permission to discard those elective priorities. You are telling them forget the margins, forget the ERS protocols, focus purely on source control.
Right, it gives them a dedicated map for the chaos.
Yes, it validates the different surgical realities rather than forcing them into a single box. And frankly, it elevates the authority of the text. It tells the reader, I understand the controlled environment of the robotic console, but I also understand the visceral reality of the trauma bay.
That's a great point. And once these core decision matrices are stabilized to perfectly reflect current clinical realities, both elective and emergent, the final step in maximizing this authoritative text is evaluating how it handles the evolution of the field. Because the confinement of emerging surgical technologies to a brief concluding section represents a missed opportunity to demonstrate how the book's timeless principles apply to the future of the specialty.
Yeah, the half-life of surgical technology is shrinking rapidly, you know? What's a massive technological leap today becomes standard practice tomorrow, and then entirely obsolete a few years later.
Yeah, which is tough for textbooks.
Textbooks inherently struggle against this current. And the vulnerability here is that while the text does a masterful job balancing open, laparoscopic, and robotic surgery as current, valid tools,
Which is great, by the way, that they aren't treated as competing ideologies.
oh, it's fantastic. But by isolating concepts like artificial intelligence-driven anatomical overlays, single-port robotics, and true haptic feedback to a short, looking to the horizon outro, the book treats them as distant novelties.
Right. But these technologies are imminent realities. They will soon interact with the book's established decision matrices, and separating them makes the text vulnerable to feeling dated way sooner.
Because quarantining future technology in a concluding chapter implicitly states that these tools exist outside of the core code the author has built.
Right.
Universal. If it's truly universal, it should be able to absorb and direct these new technologies effortlessly, rather than sitting next to them as an unrelated concept.
So the suggestion is to weave forward-looking technological adaptability directly into the core decision-making chapters to show how the code actually governs the adoption of new tools.
Exactly. You want to demonstrate that the technology serves the anatomy, not the other way around.
So, concretely, in Chapter 2, which is Surgical Anatomy, the author could explicitly mention how future AI overlays might augment the identification of the avascular planes or the ureter, just reinforcing that the anatomy remains the focal point, not the AI.
Right.
And in the robotics sections, chapters 19 and 20 add a specific sidebar on single-port robotics. Discuss the criteria for when a surgeon should transition from multi-port to single-port based on the existing anatomy-guided philosophy rather than just mentioning it at the very end of the book.
Integrating the AI discussion directly into the anatomy chapter is such a highly effective way to normalize it. It frames the AI as just another method of visualization.
Yeah, conceptually no different than looking at an MRI scan or a laparoscope.
Precisely.
But I have a highly specific question on this. Since the book explicitly states that technique alone is never enough and that tools are just extensions of the surgeon's mind, how exactly should an author write about AI overlays without accidentally making the AI sound like it's replacing the surgeon's judgment?
That is the ultimate tightrope walk for modern medical authors right there. And the framing is absolutely everything.
Right.
You write about AI the same way a commercial aviation manual writes about autopilot or advanced navigation systems. The AI is a highly sophisticated sensor, but the surgeon is always the pilot in command.
Oh, that makes a lot of sense.
For instance, the text could articulate something like, while real-time AI overlays will soon highlight the anticipated path of the ureter on the monitor, the surgeon must still validate this digital suggestion against their tactile and visual mastery of the retroperitoneal fascial planes.
Okay, so the technology is presented as a helpful suggestion that fundamentally requires verification through the foundational skills taught in the book.
Yes, you frame the code as the ultimate failsafe. If the AI hallucinates the structure that isn't there,
Which it does.
or if the single-port robot encounters dense scar tissue and loses mobility, what does the surgeon do? They fall back on the core principles the book teaches. the open techniques, the anatomical landmarks, the tactile feedback.
Right.
By doing this, the author isn't just predicting the future of surgery. They are proving that their foundational framework is future-proof. It makes the book infinitely more robust because it shows the reader how to think about tools that haven't even been invented yet.
That's brilliant. So just to briefly recap the 3 core actionable takeaways from today. First, harmonizing the promotional tone, rebranding the 80% off retail marketing into academic initiatives like trainee access grants to protect the text's immense authority.
Crucial first step.
Second, expanding the primary visual frameworks, like the code wheel, to explicitly cover emergent scenarios, not just elective ones, to prevent cognitive overload during a crisis.
Yep.
And third, weaving discussions of future tech, like AI and single-port robotics, directly into the core anatomical philosophy to prove the framework's longevity, rather than leaving them as an afterthought.
The foundation of this work is exceptionally strong, and it's clearly built on years of hard-won clinical wisdom.
Definitely.
By refining the external packaging to match the internal prestige, ensuring the cognitive models map to the full spectrum of a surgeon's reality, and anchoring technological advancements to timeless principles, this guide will serve as an indispensable resource for the next generation of surgeons.
Absolutely. We want to thank Dr.Atef Ahmed for submitting this incredibly robust and vital piece of medical literature. We warmly invite him to submit the revised work back to the critique for further feedback as he continues to develop it.
Yes, please do.
Because at the end of the day, whether you are relying on a traditional scalpel, a robotic arm, or a next-generation AI overlay, you want to make sure you are learning those skills in a quiet, respected medical library, not a neon-lit stadium.